These are my disclosures. Well, this is an overview of common causes of inflammation, and we see here that lifestyle factors such as unhealthy diet, physical inactivity, obesity, and poor sleep quality, among others, contribute to systemic chronic inflammation and also cardiovascular disease. And on the other side, we have the effects of anti-inflammatory diets. It supports weight management, improves cardiovascular health, improves blood sugar control, enhances immune function, gut health, reduces cancer risk, improves cognitive function and dementia, and improves the mood and mental well-being. I'll start by global epidemiological studies like the PURE study. It's the prospective urban and rural epidemiology. This study evaluated in 21 countries, including more than 150,000 participants, and showed that 10 major modifiable risk factors can respond for most of the population attributable fraction for cardiovascular disease, here presenting MI, stroke, and heart failure. We can see that among lifestyle factors, a poor diet, unhealthy diet, low physical activity, and low strength can explain a great proportion of cardiovascular diseases and mortality in the global, in all countries, and also in the South America. This analysis from macronutrients composition shows that it really challenged what was usually recommended, like fat restriction. In the PURE study, the authors have shown that increasing carbohydrate consumption actually increase mortality, and increasing fat, total fat, and saturated fat, you did the opposite, decreasing mortality, but with no effects of major cardiovascular disease. Talking about physical activity, we know that in this study, higher physical activity was associated with all-cause mortality and major cardiovascular disease. Even moderate physical activity was superior than no or low activity physical activity. So it's important to recommend physical activity to prevent cardiovascular disease. Now, talking about an intervention study, the Look Ahead was a study conducted in diabetes patients in the United States of America, and they also had obesity or overweight, and looked for not only for major cardiovascular events, but also changes in parameters like body weight, BMI, blood sugar control, hypertension, many risk factors, and inflammation as well. They compared intensive lifestyle intervention with controlled diet, controlled intervention, and the intensive lifestyle intervention had to reduce at least 7% of body weight with a caloric restriction, and also they have to practice more than 175 minutes per week of physical activity. And what we saw in this study at 1 year was that there were decrease in the levels of BMI, glycated hemoglobin, systolic blood pressure, increase in LDL cholesterol, decrease in triglycerides here, and even modest weight losses of 5 to 10% were associated with significant improvement in cardiovascular disease risk factors at 1 year. But when they got larger weight losses, the benefits were greater in this study. Look ahead also showed a decrease in C-reactive protein with intensive lifestyle intervention. And also they compare, these decrease in C-reactive protein was comparable to what has been seen with statin treatment. In this slide, we show that when you compare the improvements in blood glucose and also in body mass index, you had greater reductions in CRP levels. And these both were had comparable results for the reduction of CRP. So when you improve the quality of life, reduce inflammatory parameters, of course, you other clinical parameters that are linked to inflammation, you also reduce CRP. Interestingly, well, these patients, I think, as expected, had some weight regain after this 1 year. The intensive intervention, lifestyle intervention, still had a reduction at 4 years, about 6% of weight loss, but at 8 to 10 years, this reduction was of 4%. And, but the groups remained different with benefits, greater benefits for the intensive lifestyle intervention. When you compare the results for mortality, intensive lifestyle intervention did not modify this parameter. However, the participants who lost more than 10% of body weight, they had reduced mortality compared to diabetes support and education, that was the control group. Now moving to other diet interventions like the Mediterranean diet. Ansel Keys was known for his research on Mediterranean diet, especially for the 7 countries study, where he found a particular diet pattern with high consumption of fruits, vegetables, cereals, nuts, and less consumption of red meat, and especially in Italy and Greece. And he proposed this diet pyramid, Mediterranean diet pyramid, when we have foods that we can eat daily or twice a week. Some foods were more restricted, moderate portions or daily or weekly, less often, and those that can be consumed only in rare occasions. But the Mediterranean diet goes beyond food choices. It encourages an active lifestyle and enjoying meals with family and friends. This is part of the Mediterranean lifestyle, includes regular physical activity and also mindful eating and savoring each bite, not just eating fast. There are numerous health benefits of the Mediterranean diet, like reduced risk of heart disease and stroke, lower risk of type 2 diabetes, improved cognitive function, and also the risk of dementia, potential weight management if associated with calorie restriction, reduced inflammation, if you include foods with anti-inflammatory properties, and also potential cancer prevention. So there are many benefits. This is a meta-analysis including more than 1.5 million participants followed for 4 to 18 years, and they evaluated the med diet score above 2, like more consumption of foods that are part of the Mediterranean diet, and all-cause mortality, cardiovascular disease mortality, cancer mortality, and other diseases like Alzheimer's disease and Parkinson. And you can see that when you have the med diet score above 2, you reduce all these parameters: mortality, total mortality, CVD, cancer mortality, Parkinson, and Alzheimer's disease. Now the famous PREDIMED study. Okay. This study, in the study, 3 cohorts of patients were evaluated. One with the Mediterranean diet supplemented with nuts, another with supplementation of extra virgin olive oil, and the other one was control diet with only fat restriction without any supplementation. This study, the first publication that was then retracted, showed that people at high cardiovascular risk with these two diets had reduced incidence of major cardiovascular events. This paper was retracted due to some problems with the allocation of patients, especially family patients not randomized, and also the randomization and other issues. And the next publication after the re-evaluation of the database and statistical analysis, has confirmed the previous results that both diets supplemented with nuts and extra virgin olive oil reduced major cardiovascular events, but not mortality. In addition, in the study, the nut consumption was associated to less cardiovascular disease. It's a meta-analysis of 23 studies suggesting a dose-response association between nut consumption and decreased risk of coronary artery disease and hypertension, but not associated with the risk of stroke or type 2 diabetes. In this study, that is a PREDIMED study as well, the consumption of some typical Mediterranean foods lowered serum concentrations of inflammatory markers, especially those related to endothelial function, like VCAN1, ICAN1, interleukin-6, and C-reactive protein. Subjects with the highest consumption of nuts and virgin olive oil showed the lowest concentrations of these biomarkers. And in this analysis of the MESA study as well, the frequent nut and seed consumptions was associated with lower levels of inflammatory markers, partially explaining the inverse association of nut consumption with cardiovascular disease and also diabetes risk. Now moving to the polemic fatty acids, low-dose omega-3 mixtures show no significant benefits in cardiovascular disease. However, the JELIS trial with only EPA 1.8 grams per day in the Japanese hypercholesterolemic population who already consumed a great amount of fish in their diet were studied for 4.6 years. And the study showed a reduction of 19% in the MACE in the total population and in the secondary prevention cohort, but not in the primary prevention cohort. And the contemporary reduced trial evaluated the consumption of 4 grams of purified eicosapentathiols in patients with atherosclerotic cardiovascular disease or risk equivalent. There was a reduction of 25% in the primary composite endpoint and 26% of the key secondary composite endpoint. There was also reduction not only in the first event, but the subsequent events, second, third, and fourth, and so on, events with the eicosapentathiols, and also the primary and secondary outcomes divided by first and subsequent events. It also reduced, the purified EPA also reduced strokes, all strokes, ischemic strokes, and when we compare the effects of the purified EPA with the strength study that combined eicosapentaenoic and docosahexaenoic acid that was new, we see that it may be due to the placebo. We don't know exactly what is the explanation of it's just the EPA purified. But this is unpublished data, but has shown that there was an inverse association between EPA serum levels in the reduced trial with the primary endpoint, both in the cohort with established cardiovascular disease or the patients with diabetes plus risk factors. In this study that compares levels, serum levels or plasma levels of EPA in trials that used supplementation with EPA, and here in this strength combination of the EPA and DHA, we see an association with higher levels of EPA and cardiovascular outcomes. This study, the EVAPORATE trial, used the same design of the REDUCE-IT trial and compared the changes in plaque composition by virtual histology. And the study showed that decrease in low attenuation plaques, fibrofatty plaques, total non-calcified plaques, and total plaque volume. However, there were some adverse events due to the treatment in the REDUCE-IT trial. Although it seemed safe, there was an increase in bleeding with supplementation of EPA, purified EPA, and also atrial fibrillation or flutter. Atrial flutter. These results were confirmed by meta-analysis and seem to be dose-dependent. Higher dose, higher the chance of atrial fibrillation or flutter. So this supplementation with omega-3 fatty acids, icosapentathiols, has been recommended by guidelines, European guidelines, in patients with high or very high risk on statin treatment with elevated triglycerides. In Brazil, we have the same recommendation for patients with diabetes in the same setting. And it's proposed like one of the pillars for patients' secondary prevention. Now moving for the last part, the microbiome and inflammation, we know there is an interaction of the intestine and the heart. The gut microbiota perturbations disrupt the intestinal barrier integrity and causes systemic inflammation. This promotes cardiac dysfunction, and then the hemodynamic changes following heart failure can also aggravate gut dysfunction. There are many molecular pathways that link the products derived from the microbiota, metabolites, and host receptors with cardiovascular and metabolic disease phenotypes. And dietary precursors such as choline and carnitine derived from the foods, they are metabolized by gut microbiota, forming TMA, trimethylamine, that is in the liver, is oxidized by an enzyme that is the flavin monoxygenase and giving rise to TMAO, that is TMAO, the oxidized form of trimethylamine. And this affects renal disease, cardiac disease, and vascular disease, leading to end-stage organ disease. There's also an interesting association with between the microbiome with the cardiometabolic disease spectrum. In initial, these metabolic stages, even early and late phases of the ischemic heart disease, 75% of the microbiome and metabolome alterations are present, differentiated from healthy individuals. Many of these paths can be modified and be targets of experimental and clinical studies to prevent cardiovascular disease, ischemic cardiovascular disease, and its consequence. The possible interventions on microbiome composition include diet, an anti-inflammatory diet, also host enzyme inhibitors, the transplant of fecal material, also prebiotics and probiotics, bacterial enzyme inhibitors, and antimicrobials. So to summarize, inflammation permeates chronic non-communicable disease. Nutrition, diet, and lifestyle are implicated in attenuating inflammation lifestyle interventions and Mediterranean diet show that reducing inflammation, you can reduce the burden of cardiovascular disease. And the take-home message is that lifestyle interventions are an essential part of the tools to reduce inflammation and manage patients at risk of ASCVD or cardiovascular events. Thank you for your attention.